Great. Well, welcome to Dying Black, Dying White, Dying Gay. My name is Dara Cosberg, and I am the program director at Reimagine. And we are just so delighted that this event is taking part of our virtual festival. I'm going to just get us oriented for a moment with Zoom. I'm sure a lot of you are all familiar with this, and I don't think I'll bring up the slide, but in the far left corner you should see a mute button, and you can I believe there'll be a Q&A, but you'll be chatting, but we'll instruct you if there's a moment where you can unmute yourself, but keep yourself muted. You can turn on and off your video. We do recommend keeping the video on, as it does make us feel more connected to each other. There's a chat box where you can write our host, Kim, and she will be asking the questions, sharing your questions out. If you are finding the chat box distracting, in the far right corner, there's a little arrow and you can close the chat at any time. To kick it off, I'm just going to read the description of the event. How do diverse populations die differently, or do they? Dying Black, Dying White, Dying Gay, a community perspective explores relevant issues that impact the dying process in respective communities. And this virtual event consists of a group of professional end-of-life doulas imparting their personal and professional experiences to attendees to share the history and complexities that diverse communities face from medical decision-making to end of life. We will be sharing out after this event, a PDF resource guide with a lot of different resources around Dying Black and various healthcare issues, so look out for that. And I'd also like to let you know that at the closing of the webinar, if time allows, we will be ending with a guided meditation. So before I pass it off to Valoria, I'm going to read our festival intention, which is read at all of our events to just kind of bring us into a good space for this conversation. There is no life without death, no love without loss. They are in constant complementary motion. But never before in our lives has the world stood so still. In the face of distance, illness, and isolation, we are here, together, reimagining a changed world, kinder, slower, more just. We are reimagining the giving and receiving of love, the cycles of loss and new beginnings, and what it means to be fully alive. We are here. And with that, I'm going to pass it off to Valoria Walker.
Thank you, Dara. Thank you very much for reading the festival intention and being here with us today. I would also like to welcome everyone to the Dying Black, Dying White, Dying Gay, a community perspective. We are excited about talking about the topics that we plan to share today. Thank you for taking the time out of your busy schedule to be with us for the next 90 minutes to discuss this open and transparent dialogue. We will be recording this event and it will be available to you. So as I stated, open and transparent. This idea came from what I call divine shower moments that I often get between the hours of midnight and 4 o'clock in the morning. And when I got this idea, I said, oh, I know some people that I could probably invite into this conversation. And so I reached out to those who are honoring me today with their presence of their private and personal and professional perspective. And so I would like to give them a hand clap for joining me today. So that's how Dying Black, Dying White, Dying Gay, a community perspective came into existence. So why is this topic important and relevant to today's climate? This topic is important because death does not discriminate based on our race, color, sexual orientation, gender, national origin, disability, or our age. It does not care about your God-given rights to life, liberty, and the pursuit of happiness. This pandemic and really the Black Lives Matter movement has heightened the awareness to health inequalities, discrimination, and other social and economic silos that really impact how we live and how we die. It's really causing us to examine our relationships with one another. It's forcing us to realize that we're not as separated as we think we are. In this destruction, we know that what one person does or doesn't do can contribute to another person's life and even cause another person to die. So dying Black, dying white, dying gay, a community perspective looks at historical systemic factors and present circumstances that impact how the population dies differently. Our objective is really to just have a conversation to inform you about the barriers, the issues, and the complexities of the dying process within diverse population. Our disclosure: we are end-of-life doulas, not speaking for the totality of our population, but rather sharing our personal and professional experiences as it relates to our own culture. We hope to keep this webinar open as an open dialogue, safe and transparent for all of those who feel free to participate, who feel comfortable to participate. We realize that words and expressions of thoughts can be hurtful, so we remain as conscious as possible as we talk about the sensitive topics that we will be discussing. There is no intent to offend anyone or to harm anyone. So some factors that we plan to touch upon are healthcare, language, faith, privileges, advanced care planning, hospice, and end-of-life care. So as Dara stated, my name is Valoria Walker. I am located in Columbia, Maryland. I am an advanced care planning trainer. I am an end-of-life doula. I founded my private profession as an end-of-life doula called Doula by Destiny in 2016. My mother's death actually birthed my business. And really since COVID-19, I have been providing virtual companion care through my local hospice facility. And I also provide advanced care planning awareness through community partnerships located in Montgomery County, Howard County, and Baltimore City and County. I am sharing from the perspective of a heterosexual African-American woman, and I do use African-American and Black American interchangeably. So that's a little bit about me. And Shelby, would you like to introduce yourself?
Thank you so much, Val. I appreciate it. And thank you for bringing us all together in your shower moment. So my name is Shelby Carillon. I am in Richmond, Virginia. My background is in neurotrauma nursing, which I've been doing for 22 years. 4 years ago, about 4.5 years ago, I became an end-of-life doula and have been doing that with my practice, which is called A Peaceful Passing, ever since. And so about 2 years ago, 1.5 years ago, I retired from nursing and have devoted my time to end-of-life doula work. My perspective will be shared personally from a heterosexual white view. However, that said, all my work as a nurse have been in inner city level 1 trauma centers. So I would say the majority of the deaths that I have witnessed have been primarily people in the BIPOC population. So I will be sharing both of those experiences.
And Shelby, can you share with us what does BIPOC mean?
Oh, absolutely. And we have a little giggle just because we are discussing about how language plays such a part in this, in all the acronyms that people are becoming more and more aware of.
Exactly.
So that's BIPOC, which is Black, Indigenous, and people of color. Sometimes you'll see BBIPOC, which is Black, Brown, Indigenous, and people of color. So it seems to be evolving, but for short, BIPOC.
Thank you, Shelby, for clearing up that acronym for us. And Donna, would you like to take the floor now?
Sure. My name is Donna Baker, and I am a death doula in Columbus, Ohio. I started my private practice about 1.5 years ago. It's under the name Columbus Community Death Care. And aside from doula work, I'm also a home funeral guide, and I'm working with some folks down in the Hocking Hills, Southern Ohio, to start Green Burial Ground. I will be sharing my perspective today from a heterosexual white lady point of view, but since we all hear plenty of that every day, I will mostly be supporting Val and Kim as they discuss dying Black and dying gay in America.
Thank you. Kim, would you like to introduce yourself or introduce yourself?
Thank you, Val. Yes, I would like that. Thank you, everyone. Thank you, Val. Thank you, Shelby and Donna. It's been beautiful kind of collaborating, and so being able to now share it with all our participants, this is great. So I'm Kim Adams, and I'm in Baltimore, Maryland. I'm also an end-of-life doula and a certified end-of-life coach since 2010, and my business is Your End-of-Life Guide. And so I do advanced care planning and hospice volunteering. And in addition, I'm also a home funeral guide, so I do a lot of education around end-of-life and after-death care options, including green burials.
Thank you, Kim. Thank you, ladies. So I want to start with the factors that influence dying Black in the United States and the mistrust of the healthcare system. And if I have time, I will also bring in factors related to faith and language. But we know that healthcare is a problem for most Americans, but the mistrust of the healthcare in the African American community is really based on our history. And one of the most horrific events that shape American history is the slave trade. And it's a dark area that most of us don't want to go back to, but it's the start of how Africans were treated and or mistreated by the United States, the system, and as they were being transferred and migrated to what we call this new world, the Middle Passage. You know, Africans were pretty much stripped down. They were not considered to be humans. They weren't treated as humans. Right to the New World, they are estimating between 20 and 50 million, with less than 30% surviving. You know, Africans were stuffed and in the belly of ships. Many suffocated and died. They were beaten, they were bound, they were force-fed. Women and girls were constantly being raped. So when I think about how George Floyd died and the message that came about, you know, I can't breathe, I think about the Africans, the many Africans that were hung, that could not breathe because of their oxygen being cut off. So when I look at dying Black, I have to start with my roots. I have to start with the historical systemic forces, factors that began back in the 15, 16, and 1700s as Africans were brought into the New World. And I know a lot of people normally talk about the Tuskegee syphilis study, but I really want to talk about the immortal life of Henrietta Lacks. I really found out about Henrietta last year. I listened to the audio book and Audible, and her life really started. A person from the state of Virginia, and she moved to Turner Station area in Baltimore. And Henrietta had cervical cancer. And you ladies can jump in at any time if you want to, you know, add any additional comments. But researchers from the medical institution, to put it nicely, pretty much raped her of her cells, They practically took every cell from any part of her body and used them to create the first immortal human cell growth and culture without her consent. So because her cells lived outside of her body, when they was extracted, they were really, like I said, produced and reproduced and reproduced and sold as a billion-dollar industry to different corporations globally to use her cells for treatment, and she wasn't even aware of it. They really didn't even call her Henrietta Lacks, they called her cells HeLa. But they were instrumental in vital developments from polio vaccine, vitro fertilization, cloning, gene mapping. Most of us have her cells in us right now. And again, this happened in the 1950s. And I was just reading this week, Monday, published an article stating that her family will be getting profits now, just now, from what was going on. And the bad part about it, that in addition to taking advantage of her, same thing to her husband and her children, they wanted to start testing them and testing their cells to see if they could see if their cells would die outside of the body. So you know, when you think about historical factors of dying Black, historically, the predominantly white medical institution have repeatedly not provided adequate health care to people of color.
And Val, this is just interesting because when we hear people talk about the racial inequalities in healthcare in this country, medical journals often use the phrase large, pervasive, and persistent. And that's exactly what you're describing, right? I mean, it's deeper than a lot of us could even imagine.
Yeah, it is. It is. And we just try to, we just have to try to continue to put this information out so that people will know and understand. Because, you have some people that just don't understand, the healthcare system has treated me well. I've been doing great, but you definitely have to start with the root of the cause and see how that has progressed through the decades to what's currently going on. Now it's just too many lived experiences and too many examples of mistreatment when it comes to Black Americans and African Americans, about how healthcare has really failed them. When I think about the systematic factors between clients, doctors, and the patient-client relationship, and how do we think about trusting doctors, particularly at the end of life when we see so much historical mistreatment, that has happened in the past. We just don't, most of us just don't trust the medical institution. And I often hear where it says, well, African Americans often say at the end of life, they choose do everything to keep me alive. But, when we suspect that the medical system is doing everything not to keep us alive, that's why most cases I feel African Americans go in saying, do everything to keep me alive. And so, I often, and I don't want to ruffle any doctors' feathers or any medical professions that may be on the call, but for me, when I think about the oath that doctors take, the do not harm oath, I wonder, do their biases and their prejudice get in the way of their promises? If a doctor is not educating me, if I have to continually advocate for myself, if he's pushing one option versus giving me all the options, is he really harming me by not educating me? Because by not educating me, I'm not being able to I can't make informed decisions, right? And so I often think about, you know, how doctors treat me as a patient. Do they really treat me different than their white patients? Do they give me less attention? Do they give me less empathy? You know, and I often kind of think about that and wonder, is that really best practice? And what is best practice? Is best practice different from me as a Black woman than it would be as a white woman? And so I think, you know, not to go on with this, but if there's any questions or anything at this time, or if any ladies want to jump in to kind of go with the flow of what I was talking about.
Continuing on like the mistrust, I think when you have mistrust of a society that's primarily white, and then you're in your day-to-day life, and then when you're the most vulnerable, when you're ill, when you are sick, and somebody who looks like that comes into the room to treat you, that person might be the most compassionate healthcare professional around, but there's that automatic mistrust, and it's a barrier that as a healthcare professional we have to build trust. We have to one-on-one, where I have seen it look very different if a Black doctor comes in and is serving or consulting with a Black family. I think that right there is a sense of, oh, this person has seen the world sometimes like I see it. And it's quite sometimes a benefit to have cultures in that sense.
I agree with you, Shelby, and I don't feel like, you know, every doctor or every client-patient relationship feels that way. I do feel like there is a different connection when a Black doctor or nurse or doctor comes in to talk to me. I feel like, yeah, I am going to get all the information that I need to make an informed you know, decision. And so you are right when it comes to, you know, that different connection, you know, that really makes a difference when it comes to having types of conversation. And if that connection is not made at the beginning of any onset or diagnosis, then you definitely are not going to pretty much get anywhere when it comes to talking about end-of-life care and advanced care planning.
You know, too, I think though there's a huge component of this that is just based on false beliefs. I know that the National Academy of Science published the pain study that I think a lot of healthcare professionals are familiar with just in the last few years. And even in that study, you know, it showed that people who were interviewed were under the impression that Black folks literally had thicker skin or had less nerve endings in their skin, right? And so even in the best case scenario, let's say that you have a doctor who is anti-racist, I still think that maybe there's a flaw in, and even the training, just the biological differences that a lot of healthcare professionals are trained understanding or believing. There was recently there was a med student in London who co-wrote a handbook that's being used to identify diseases on Black and brown skin. And the reason that he even came to the understanding that he needed this guide was because he was having trouble diagnosing folks with different skin than was being presented in his medical handbook. You know, things like conditions that would say, you know, look for pale skin, or, you know, blue lips would be a sign to look for. And in certain populations that wasn't even a sign that he could identify. So, you know, it's I think it's even a deeper issue and an educational issue as well.
Yeah.
And we have a couple.
Sorry. Go ahead.
We have a couple of comments in the chat, and thank you for answering the question about tending to trust Black doctors more. And another comment I think speaks to what Donna was just sharing about the pressure on Black medical students and residents to conform is incredibly strong.
Wow.
Mm.
So.
Yeah. So I think a lot of it, when we talk about education, we know that education needs to be one of the factors when it comes to training medical students. And all of us can stand a couple of courses in cultural competency as we relate to one another, you know. So if you don't know my language, you can talk all you want to, but in my head, I'm pretty much already making my decision.
And Val, also, you know, we can't silo any of our discussions that it's just a culture that we're dealing with, but you also have to think of the socioeconomic impact that primarily when we're looking at people in the Medicare, Medicaid, there is a majority Black. And so now we're talking about access, just the sheer access to medical support, trust or mistrust aside, that we need to acknowledge. You know, I was speaking to a nurse who is an end-of-life doula. Her background, though, is in nursing in the inner city, actually, of DC, in hospitals that are primarily for indigent populations. So she said it's primarily people of color, undocumented. And she says it's hard to get even the medical equipment that they need to that hospital that is considered basic care items because it's not generating income.
Wow.
So when you have those things, so yes, it's a socioeconomic issue, but let's look at the population that is lumped into that.
Right.
And they aren't getting the basic, you know, sequential stockings, which are those things for all of you who've been into a hospital that you put on your legs and it blows up and relaxes. She said, you know, anybody who's had a surgery needs to have those on their legs. That is basic care. But she said, we really don't have them in the hospital, because there's not enough money. What we have is broken. So that's going to lead to higher risk factors of deep vein thrombosis and throwing clots and throwing strokes. And so it's just this whole cascade that we need to uncover that rug and look in that dark corner.
Right, right. Well, Shelby, since you have kind of opened up that, would you like to kind of continue with your perspective from your community?
Sure. So again, it's not siloed because socioeconomics has a huge impact on the experience that we have around death and dying, regardless of our skin color or our gender identity. That said, in the populations that I have seen, you know, we're talking about the Black population mistrust of the healthcare system. What I have seen is almost the opposite. It's the privileged white thought of it's always going to be there for me. It's always going to be there when I need it. And it really, I have seen it. The problem with that is, specifically if we're looking at end-of-life care and hospice, that people are going in with the wrong expectation of hospice. Is, you know, they think, oh, well, hospice will be there every day. They're going to send, you know, volunteers around the clock. And unfortunately, and I am a huge hospice fan, but that's not what hospice is. They don't have this huge breadth of that kind of support. And so I found a lot of people, when they're frustrated with hospice, is when I ask them why, when I realize what their expectations were. That's where it's a different experience. When people of white skin are told that they can't be helped, or they have to wait for, you know, a month or two for an MRI or a CAT scan or for a diagnostic procedure, the idea that they have to wait, like, that is just that they should be able to get what they want. They should be able to get it now. It is their right. They've worked for all these, you know, decades, and this is their right. They should have everything at their fingertips. Where I don't find that as much in the other cultures. This privileged idea of it's owed to me kind of idea, thought process. So it's kind of the difference when we come to trust and mistrust. And I think the other big difference I see between the white culture and the Black culture, so regardless of gender identity, but just if we could take those two different cultures, is family and the role that family takes place during the end of life. In the white culture, when I walk into, at the time, whether it was a hospital room or as a doula, it's really those deep, close-knit family situations. So it might be a spouse or older children, maybe siblings, but normally it's just a very small handful of kind of, their people. When I walk into a room of somebody who is of a Black culture, it is a cultural difference. They look at family very differently, and I envy them, because what I had to learn as a nurse, I was not taught this, is like the word cousin in the Black community. That's like as close as a sibling. Like if you were cousins with someone, they might as well be your brother or sister.
Yeah.
So when we have, we're restricting visitors and we're like, sorry, only immediate family only. Well, in white version, a cousin is not an immediate family. That's only, siblings, spouse, children. But in the African American community, that cousin is just as close as a brother or sister.
Right.
You have aunties and uncles who are not aunties and uncles by blood, as white cultures would look at what an uncle and an aunt is. So you come in and it is this beautiful community that sometimes they're like falling all over each other to fit in this room to hear you speak or to see the care that you're being given. And it's just a different energetic feel in that space. And so for people who make the decisions on guidelines around visitation, I sometimes question those, that we really need to look at, what is best, who is best to come visit, as long as certainly as it's not risking anybody's safety and doctors and nurses can come as they need. That goes for anybody. But that's probably the biggest two differences I see. Donna, I see you unmuting yourself.
Donna, get ready to jump in.
So how many Black cousins do you think it takes to make a white cousin?
That I don't know.
Well, another thing I wanted to point out is that we, I know in the doula community, we don't see a lot of Black families employing doulas to assist them. And just when I'm hearing you saying these things, I wonder, there are so many reasons that could be. But I wonder if, and maybe anyone in the audience would like to address this, but is it naive to think that Black families who are would be in need of a doula are just relying on each other in a way that maybe white families aren't able to? I know in my own familial situation, I have my family here that I've built with my partner and our kids, but I don't have my family of origin is no longer around. Do you think that Black folks are just relying on each other in a way that they don't need the assistance of doulas?
Well, for me, Donna, when I think about the assistance period, we have just been used to, and thank you for putting that question. Now and Shelby, I thought about Big Mama's house when you talked about the families, right? Because as a hospice volunteer, when there's a African American, Black American there, there's plenty of times where I can barely open the door because the grandchildren are on the floor, the siblings are on the floor. And I also think about the question that Donna put, how many Black cousins would make a white cousin. And I have girlfriends that we are not blood, but they're my sisters. And if you do anything, or if anything is done to me, there's going to be a problem. And so, but I think when it comes to assistance, when I go back to, again, the historical factors, African-American women particularly were always serving. They were always cooking. They were always taking care of white women's children. Big Mama, she is the matriarch of the family. So she's cooking on Sunday and everyone is sitting at her table respectfully. So when it comes to assistance, we are always the working class. And so when it comes to end of life, that's not going to change. We're still going to keep pace with what we have always done. And that's working to take care of our own selves and not really relying on an outside source to come in and care for us, particularly at a time that's as sacred as end of life. So, you know, those are my thoughts around, you know, community and end of life doulas supporting, you know, the Black family. But I definitely feel like education is needed in the Black community to really expose the value of having an end of life doula, you know, in the midst of a Black family who's losing someone, because we still can add value in that, because everybody has family dynamics. In most cases, there's a cousin who feels like I'm in charge, and no, that's not necessarily the case. And so an end of life doula can come in and smooth that transition and focus on the dying client versus all the sometimes negative issues that are happening within the family. And so you do need a third person there as a neutral guide to
Well, what is any of the doulas on the call, what are your experiences with a percentage of people of color, or I guess just of Black folks having their advanced directives done?
Kim, are you getting anything?
Just a couple of comments from the first question, that the comment about church being a huge support in the community. And then we also had a comment about we seek help from our own community, and this doula is not part of the Black community. So I think it speaks to that we are speaking from our perspectives, and then kind of the generalization. It's like there'll probably be examples of each of those opposite from what we're sharing, but those were the two that have come in.
And Donna, to answer your question, is I can't say percentage, because I've had so many people that I've served over these last decades, but it is a large majority of the Black community does not have advanced directives. And Val, I would love to open up with your expertise in the field. My experience has been a few of, and going back to that comment that somebody made about faith-based, I have found as a nurse, my realization about the role that faith plays in the Black community to the minister or the reverend or the preacher really holds this highly esteemed position in their community. Miracles are always possible, and talking about advanced directives negates the possibility, almost you're turning away from Jesus or the possibility of a miracle. And it's something that they look towards their faith leader to help them make those choices and decisions versus looking at the healthcare industry, which, going back to the very first thing Val was talking about, they have mistrust of anyway. So who they do trust is somebody who leads them in their faith, who looks like them, and that's, I think, where they put their trust. But Val, what are you seeing as far as that?
When I look at, when I talk to faith-based ministers, talking about advanced care planning is almost like having a new conversation. You know, they are aware of it. I've had a couple of virtual calls where I've had churches or church congregants on the line, and they talk about advanced care planning. But for the most part, it's talked about, but not, you know, the plan does not go into effect, because Americans have a problem with talking about dying anyway. You know, there's a stigmatism around talking about dying. So, but when I turn and I talk to the white community, they are very educated about advanced care planning. They know about advanced care planning. They've done advanced care planning. I think compared to between Black and whites, I had this somewhere, but I think between the population, I think 44% of white Americans have advanced care planning, and it's less than 20% when it comes to Latinos and African Americans when it comes to advanced care planning. So yeah, there's definitely a difference.
Mm.
Kim, do you have anything, or
Yes.
are there any more questions we want to
Sure.
put forth? And if I have time, I'll talk about the faith, after we talk about some other issues.
So to follow up on that, one of the questions came in is how aware do we think families are of the work of end-of-life doulas? So in addition to advanced care planning, but the role of doulas, because this individual had just learned about it.
Mhm. Anybody want to jump in and take that?
I mean, I think it's it's a new field. I got in it, like I said, about 4.5 years ago, and just in 4 years, the amount of talk that's going around it. I mean, it's every year there's more and more out there, but I think we still have many more years before it becomes commonplace. Some people still don't know what a birthing doula is. So, but I have seen a huge jump in interest and popularity around end-of-life doulas and end-of-life care, whether it's looking at the community or even our professionals in the end-of-life field.
Yeah, I agree. I think, unfortunately, with COVID-19 and us actually seeing death all the time on the media now, death, like I said, has brought in a heightened awareness, and the role of an end-of-life doula is definitely changing and getting more, awareness out as far as our role and how we can help families. Donna? No? Kim?
Yes, this may lead you, Val, into speaking about the faith. We have a participant that says, I live in Oakland, California in a racially mixed senior community, and most folks would listen to their church elders to better prepare and even introduce the idea like a doula.
And so since we're talking about faith, I just want to do a data check here. When it comes to absolutely believing in God, 83% of Black people have an absolute belief in God, composed to 61% of whites and 59% of Latinos. And when it comes to having a religious life as being an important factor, 75% Blacks feel like that's important to have. And this is according to a Pew Research survey that was put out. So when it comes to having a relationship with God and having it as an important factor in one's life, 75% of Black Americans believe that, 49% of whites believe it, and 59% of Latinos believe that. So going back to the history again, religion was basically the only time that we was able to assemble. Besides working in the field all day, we weren't able to communicate and assemble. So we had opportunities to express our religion freely, and really historically from birth to death, dancing and singing were expressions of celebrations and communication strategies to escape from. And so we understand, when we think about our religion, we understand and we can relate to the message that's in the Bible where Moses delivered people who was in bondage from Egypt. We believe, and I'm saying we, but remember, I'm not expressing the totality of the population, because everybody's like, how dare she say that? So, but I just expressed the percentage of African Americans who believe that, they believe in God. So when we talk about God, we think about the birth of Jesus Christ. We look at how he endured the humiliation from his time, the unjust brutality that was placed on him, and the suffering really that led to his death. So all of that is a part of our religion, and it helps us to survive. Most Black Americans we're dealing with two things. We get up in the morning time and we either live or either we're going to die, and we make a choice, and our faith keeps us at a foundation to where we just know how to survive. We just, under any circumstances, we just know how to survive. And I know this may ruffle up some people, but in my opinion, one of the reasons why I feel that African Americans don't talk about advanced care planning or palliative care and hospice care is because we feel like our faith, we may not be loyal to our faith, you know, if we put a plan in action about our death. Because just like Shelby said, we're often waiting on that last minute miracle of healing. And so if we put a plan in place, you know, then I'm saying, my faith, you know, am I not loyal to my faith if I put a plan in place saying, do this if this happens, or don't do this. And so sometimes I think our faith conflicts with us making a informed decision on advanced care planning. But I do advocate for having an advanced care plan, because even with our faith, we did know that Jesus Christ died, and no one is living to 300 and 200 years old. So we know that we will die. And so we should have an advanced care plan in place.
And Val, going off that, I know when I started out as a doula, I wanted to let my community know that I was here. This is what I do. This is what I offer. And so I went into all the communities. But when I realized when I was going to the African American communities, they were looking at their ministers like, what is this girl talking about? And so what I realized is, if I really want to go into the African American communities, you have to go in through the faith leaders. You need to have, and you need to sit and you need to talk to the ministers and the preachers and talk to them about how you see death, how you see death and dying, how you see death and dying can be different. Because they seem to be the one that the community looks to make those decisions. Is this so?
And you also have to educate, you know, ministers and pastors. My brother is a pastor in Louisiana, and he and I will be doing a webinar in August where I will be talking to his congregation about advanced care planning. So you have to go into the community, like you stated, and you have to talk to faith-based leaders, and you have to educate them on advanced care planning and the role of and the value of end-of-life doulas. I actually did a talk a couple of years ago to a Baptist church, and after I finished, the pastor said, "Oh, well, after you have educated me, I'm going to go home and I'll be talking to my mom about setting up an advanced care plan." And so it's really about educating the community, particularly the Black community, because the white community, they know the value of advanced care planning. Kim.
Thank you, Val. So just to kind of wrap up, I think everything that's been shared here, there's a couple comments about hospice. And so again, back to the education for individuals about hospice and the usage of it earlier, later, versus white versus Black. So I think you touched on that a bit, and more questions, or I should say more comments about the importance of the faith communities and the pastors and ministers. So great.
Well, at this time, Kim,
Okay.
any reflection you have for us?
All right. Well, everything that's been shared, I think, as I begin to share a little bit about the gay voice, and as Val said, I'm not representing the entire gay community. Certainly, I think it's important to start with and acknowledge the intersectionality, and some of that came up in some of the questions and comments, intersectionality between all this. We can't just, say white, Black, gay. There's intersections among all of that, in addition to gender. Throw that in there. So as a white gay woman, my experience is quite different than, let's just say, an African American gay man or a Latino trans woman. So again, there may be some just generalized pieces here, and again, speaking from my experience. So with the gay community, there's similar to, as Val was speaking about, there's a generalized invisibility, right, of the LGBT community, and especially among older LGBT elders. And because part of that is also we live in a heteronormative society. Like we live and breathe that straight heterosexuality is the assumption, and the assumption is the norm, and the assumption is that that's superior and or natural. So that's the first piece in terms of just recognizing, and of course it's becoming more and more popular, or maybe popular is not the right word, more and more evident with people stepping up and stepping out of the closet and feeling safe. And I'll get to a couple of those barriers of why people, don't choose not to do that or need to even go back into the closet. Yes, we'd say 2015, now we have marriage equality, so we're all good. People can get married, so what's the big deal now with gay folks? But there's still places, even here in the US, where it's unsafe to be in a same-sex relationship or to be serviced. Think of the people that want to have a cake, right? The bakery that refuses to serve gay people because of their own fears and whatever. So or you can even be fired from your job, right? So that, yes, we have marriage equality, but yet that has not kind of just taken away everything. And there's also a lot of gay folks that are not interested in marriage because, and this is a whole nother webinar, but because they see it as a heterosexual institution. And so, there's that piece. However, I do see things changing. There's so many laws that protect heterosexual folks in marriage that are now granted to gay couples. So it's really important that people are aware of that as well. And also the fact that there's a number of countries, I think it's around 11 or 12, and I was doing some research to see that it's illegal and it's punishable up to death to be in a same-sex relationship. So we've come far from the Stonewall days in the 60s, and yet we have lots to come. So speaking about sexual orientation, it's really just one piece and one part of who a person is. So in many cases, having to hide that due to predominantly other people's fears can result in discrimination and rejection, violence, being disowned by your family. So it's challenging for a lot of people to step out, and so people will retreat in. There's also a piece around language we'll get to in a little bit, but just even people that are feeling that they can't even be honest with who their life partner is, and they say the word friend to make someone else comfortable. So those are just a couple of the pieces in a general sense. Yes, many people have come out of the closet, but they're now feeling the need, as I said, to go back, and especially toward end of life. There's a lot of times a continual need to continue to come out. If it's a new healthcare provider, or if it's a doula, or if you're in a hospital setting, or even in assisted living. And so the risk of, do I disclose this information? What kind of feedback am I going to get? What kind of, how are people going to react to me? Causes people to kind of hide for their own protection. And there's a lot of internalized homophobia, right? The negative feelings that LGBT people have toward themselves because of being gay. So there's a lot of kind of pieces around that cause people to go back into the closet. So before I kind of jump into some barriers, Donna, Shelby, Val, is there anything you want to share just on the general piece around that?
Well, I was just curious, something that you said about that sort of suppression that's really can be triggered at a diagnosis or when at a determination of an illness, and that the suppression that comes with that. But then I even think about taking it a step further, and once that person is actively dying or the person dies, it can be worse than suppression. I mean, it can even be a kind of erasure. A lot of folks who die, who aren't able to have their partner listed on their obituary, folks that aren't in a position to, trans folks whose families don't claim their bodies upon their death and are often buried without any sort of any name recognition. I was surprised to recently learn that Susan Sontag and Sally Ride, two of the most, influential queer women of this modern time, who died with their obituaries not mentioning their relationships. And, in the past, I know I've seen obituaries and even eulogies reference gay men by saying that they were lifelong bachelors. So, you know, at some point, it's not even suppression, but it becomes something much more dangerous. Is a form of erasure, really.
That's really excellent points. Yeah, you know, as you're speaking kind of about even for trans folks that, you know, they say they use their given name as their dead name, and families will just be so persistent
Right.
because they are so not interested in wanting to acknowledge who that is. I'll get to a little bit about family and friends piece, but thank you for bringing that up now. Yeah. So regarding some of the barriers, and again, there's more than this, but just to touch on a few, just to give us a flavor. One of them is healthcare. You know, there's a real mistrust within the healthcare system about not being inclusive and, you know, discrimination. You know, I worked as a case manager at a community health center back in the early 90s with people with HIV and AIDS. And of course, you know, back then, that was known as the gay disease, right? Because it was initially gay men who were dying. And being gay has been linked to illness and disease. Even at one point back in the AIDS epidemic in the early 80s, it was called GRID, gay-related immunodeficiency disease. So if that doesn't kind of stigmatize that the gay community is, you know, a disease or illness related. So that I think speaks to a lot. And yes, we've come far along and continue to do that, but that's kind of one of the underlying features is around the fact of kind of the disease or the illness. Something's wrong with you medically if you're gay. Then, you know, there's many times where healthcare providers want to avoid the topic in the healthcare community because of their own discomfort or they don't know what to say. So again, this can result in preventive screenings that are necessary that aren't you know, provided to the individual. And again, yes, there's this balance of, you know, it's the gay individual really needs to feel comfortable and share who it is that they are. And yet you need to have a safe and welcoming environment to do that. So, you know, it's a both and. There's also in the healthcare community, you know, patients wonder, will their partner or spouse be recognized? You know, again, that uncomfortability with doulas, doctors, healthcare providers, hospital, assisted living, you know, are they, because of their own uncomfortability, going to want to be like, not wanting to do that and not wanting to be recognized, a very important person in that individual's life. You know, speaking of the healthcare, so I've been in a 30-year relationship with a woman and out most places. You know, I decided that, you know, I'm living who I am. But, you know, even I sometimes inside my gut, you know, especially when I'm meeting a new doctor for the first time, there's that little bit of hesitation. I watch their face, I watch their body language to sense their openness, their discomfort. You know, if I say wife or female partner, you know, how do they respond to that? You know, so even after all these years, there's still a little something in my gut. I'm so much more comfortable if the doctor, the healthcare provider, or the doula, or whoever is LGBTQ. Similar to as Val mentioned earlier, you know, if you're African American and you have an African American doctor or doula standing in front of you, there's you don't need to explain. There's a comfortability. There's something there that the comfort level is there without needing an explanation. So I just share that even after all these years, I'm still kind of get that little bit of a twinge every once in a while. And I, you know,
I would say, Kim, I don't mean to, but you brought me back to a memory as I'm going to separate my two experiences. As a doula, I tend to meet people and they're, you know, just, it's an open communication when I'm meeting them, and that comes out whether they're gay or straight or have partners or whatever that looks like. But when I have my nurse's hat on, when you're doing those intake forms, it is like as cold as it could be. And you'd be like, are you a homosexual? Are you a heterosexual? Have you had sex with a woman? And A, it's very cold and off-putting. And B is if you ask enough of that to the heterosexual population, you keep getting like, are you kidding me? Why are you asking me that? Like, that's ridiculous. What do I look like? So then you want to ask those questions as a healthcare provider, but you're getting the negative fact that it's really hard to, you're almost throwing the question out. Actually, sometimes very much when I throw the question out, do you have an advance directive to the African American community? I've received a lot of why do I need that? And kind of, it obviously triggers something. So it's kind of this apprehension where the healthcare community needs to know, but I can understand it. It comes off as a very cold question. Are you a homosexual? It's like,
Right. Very
yeah,
yeah.
right. It becomes this label and not this just human dialogue experience.
Mhm.
So I could see where, even though as a woman in a relationship for 30 years who knows who you are, it's still an off-putting question.
Yeah, it is. And I think that there's ways, and we'll get to language in a little bit, that, to be able to kind of invite the dialogue so it feels like the healthcare person is getting the information they need, and you also feel like you're a little bit more than just, I need to check this box in a paper, so tell me, rotely like that. But that's a great observation. Yeah. Yeah.
I have a client right now, and he and his partner have been really hesitant to contact the VA. The dying partner is a veteran, and I guess I feel kind of embarrassed to say this, but I didn't even really realize how much of what you're saying might be playing a role in that decision. They've also been somewhat hesitant to get involved in hospice care, but I just having to go through that process again of going through, describing their relationship and identifying their roles in that relationship and worrying about getting the care that they deserve and need. I'm noticing it as a barrier. And also the client who's dying was interested in having his body donated to the Ohio University School of Medicine. And I learned that they wouldn't accept his body because he's HIV positive. And I had to share that with the couple, which was also a very difficult conversation to have. But, I think that I'm just becoming more and more aware of the constant outing process that folks go through. And it's not fair. It's really tough to witness, and it's definitely not fair.
Yeah, and there's so many layers, add race to that, add gender to that, add trans to that. So, yeah, and then I think that there can be more, again, I think the theme here throughout all this is education, educating folks around sensitivity and inclusion and asking questions in a curious way together, as opposed to, as Shelby was saying, I got a form in front of me and I got to check the boxes or whatever, especially if it's whether you're a doula doing an intake or a physician needing to do that, or an assisted living. So great comments.
So Kim, I'm interested, you were talking, or you mentioned earlier about language, and we're like at 4:37. Can you touch on that just a little bit? And then maybe if we have some questions out there from the audience, we can invite them into our conversation.
Sure. And we have a few in stuff that I'm going to kind of get to, so thank you for that. So language. And then hopefully I'll be able to touch on family, because I think that's an important piece too. But, again, just following up on kind of forms and things, is there an inclusivity in terms of what's listed in an intake form, regardless of where you're, whether it's hospice or end-of-life doula or hospital, be inclusive of sexual orientation as well as gender identity. In terms of married, if the person says that they're married, don't just assume if they're a female standing in front of you that their partner, their spouse is a female. So that, really just, again, I think it's the education and being open to the language of inclusivity, and also just having the awareness that it's more than just a heterosexual world that we live in. In terms of even the definition of family, at a hospital or at a hospice facility, if their policy is, or their definition of family is just, the immediate family, but you have a partner here, a spouse, and there's no actually forms or anything that documents that, which is another reason why I'll get to end-of-life planning is important, to cover yourself for that. But again, are you open to the fact, if I say, my partner, are you going to say, oh no, it's only family? Well, I am so you really don't want to get into that conversation in the hallway of a hospital, right? So the definition of family, I think, is important. fostering that environment of curiosity. Kind of goes back to what Shelby was bringing up, that question. When meeting someone for an intake, ask questions such as, who's the most important people in your life? And let them know that you're open to hearing all about that. So it's not like, are you married, are you single, but who's important to you? And then they share that and just be curious. Many more heterosexuals these days are using the word partner. So ask what their partner's name is. There's another way to gather information. Unless your partner's name is Tony, which is mine. So a lot of times people automatically just assume it's a guy. So, but yeah, ask and just be curious. And please don't say you have a gay friend or family member so you understand what's going on. Kind of like the black thing, right? I got a black friend, so I kind of know how it goes. So that's just a little bit about language. Can I just touch on family for a second, Val? I think we have. So there's this huge piece, right? Family of choice versus family of origin, which, obviously, as we know, the one you're born into. And in the gay community, a lot of times the family of origin is not supportive. So it's important that, for some of the reasons I had just mentioned, that the gay community has end-of-life planning in place. Because, for example, if your wishes are not documented and there's no marriage, so it's not legally married, then a family member who you may be estranged from or have a really dysfunctional relationship with, guess what? They're the one making the decisions, even if your partner is standing right next to you. So and they can step in, and we know how crazy death makes people in general, and then add this to it. So according to SAGE, which I see a few of you have commented in the chat about that, which is an organization out of New York City, hugely supportive of the gay community. SAGE stands for Services and Advocacy for GLGB elders, so that they could get the acronym right. Gay people are twice as likely to be single and live alone, especially gay men, 4 times likely to not have children. So preparing for end of life and advanced care planning, working with a doula, getting your wishes finalized is so important. Just a really, really quick thing. So my mother-in-law died in 1994. And my domestic partner at the time, because we were not granted marriage, so Tony was my domestic partner, because that's all we could get. We immediately went to an attorney after her mother died to get our end-of-life paperwork together. Now, she's an only child, and her dad had died like 2.5 years earlier. So nobody would stop me. Probably if she died, she didn't have any family. However, I would hope that my family would have honored her wishes as my partner if, in fact, I had died. But again, without any legal protection, it's kind of risky. And so, again, I told my parents, it's not that I don't trust you. However, we need to do this for our legal protection. And, at that time, we were only together 4 months, and I hadn't even officially come out to them or my siblings. So that was my own internalized stuff. So, again, I had the experience, and I thought, whoa, we need to put stuff together. And end-of-life planning was vital to be able to have those protections. So those are just a couple of things. I see in the comments that people are saying, how do gay people, die differently? And I'm not sure that we die differently, but I think the experience is different given some of these lack of awareness, lack of inclusivity that, I've just touched on.
And Kim, I do want to make a correction. The studies that I talked about earlier states that, and this is in the resource guide that Dara talked about earlier, that around 24% of older Black Americans have advanced care directives compared to 44% of older white Americans. So Shelby, that kind of answers your questions with wondering, when we're talking about the percentage of Black Americans versus white Americans. We're now at 441.
Val, can I say just one more quick thing?
Sure.
I feel like to address the question, how do gay folks die differently? I guess in my gut, I kind of feel like they do, and that's because and the way that it's different is that there just has to be all this explanation, right? Because, and the same with the Black community, there just has to be all of this stuff that Shelby and I would never have to say or explain. And it's different in the sense that you just, you know, you have to just be hyper vigilant. And I think it's also different in the sense that, you know, a lot of the things that we've talked about today and a lot of the necessity to over explain these things, you know, it really just, this all adds up to this incomplete picture of who we are as a society, who's in our society and who shapes it. And when these voices, you know, need to speak louder to be heard, then it, you know, it's misrepresentative of who we are as a culture. So for me, that is different. That's it.
Anyone else want to share? And then I'm going to turn it over to Dara to begin to start the closing process. No? Well, thank you, everyone. We're not going to close at this point, but I am hoping that this divine shower moment has really helped you to understand from our own personal and professional perspectives, and as being end-of-life doulas, how we see the dying process within our respective communities, respective communities die differently. Thank you for, again, being here with us and giving us your time. And at this time, I'm going to transfer the program back over to Dara, and she will lead us out. And again, Donna will be ending with a guided meditation.
Thank you. And wow, that I really do think I could listen to each of you for like several hours to yourselves. So it's just, yeah, I was just taking in a lot. That was a really, I don't know, enlightening conversation. And to close things out, I have 2 closing questions, and I'll ask them one at a time, and you can go around and respond. So the first one is, how can end-of-life doulas and members of the community work together to achieve and deliver a better dying experience that is inclusive? So how can end-of-life doulas and members of the community work together to achieve and deliver a better dying experience that is more inclusive?
And I kind of feel like what we did today is a good start in that direction. I hope you all feel the same.
Yeah, I do. I think it's going to, we definitely talked about education, you know, a lot through our conversation today. And so we have to join as partners, you know, in the community and see what's, you know, and just look at dying without placing any sexual orientation or color or race on it, and understand that this person that we are looking at is at the end of life. You know, they're at the last moments of their life. And so our focus really to be, for me as an end-of-life doula, is to focus on serving them, you know, to make sure that I am honoring them, and that they are leaving this world as they transition as best as they can. And how can I facilitate that, you know, for them? And so working together, in order for me to be able to do that, whether it's a Latino family, a Hispanic, you know, a white family, I have to educate myself on their community in order to be able to serve them better as an end-of-life doula.
I think you took my answer, Val. You really said it perfectly. It's literally just to be that, and to go into communities. They're not going to come to you to knock. You know, don't be afraid to. You know, I facilitate lots of death cafes in my area, and I try to make it in every area of my city. The good, the bad, the dark, the light. Doesn't matter, but I try to be available as much as I can. And going back to Donna's comment, is educate everybody.
Mm-hmm. Yeah. Because I know that we all agree that we are walking into a sacred place, and we're trying to, you know, keep that space, you know, as sacred as possible. And the only way you can do that is coming in as a blank person without any agenda, and not really looking at or trying to, basically remove your biases and prejudice as you serve the person who is transitioning.
Absolutely. And I would just add one other word to that, because what you said is how I feel as well, is just be curious. Be open and curious and ask. Yeah.
Dara, you said
Yes.
you had another question for us?
Yes, we have one more, our last and final question. Oh, gotta get ready. Okay, what would be the first factor we would look to change to promote inclusiveness within the dyeing industry? So what would be the first place you'd start? The first factor.
I know mine is, I also help train other doulas, and I get a lot of doulas that look like me wanting to go into different cultures, and it's very much a version of like white saviorism. It's very much like, let me show you how it's done. And I, as much as I can, speak to the, not that, everybody should serve every culture that comes to them for help. And I'm not saying it needs to be and should be segregated. However, I think my job as a doula is to find leaders in different communities, in marginalized communities, find leaders that would make great end-of-life doulas or are in the death profession, encourage them to get into the death profession so that they can be a voice in their community as well. So instead of jumping, saying, I need to serve you, it's find the leaders in that community and encourage them to have a voice.
I think just continuing to elevate the voices of those around us, that's really important to me right now in my work.
Yeah, I would agree. I think elevating the voices and also listening. I know certainly, as Shelby, you said, we want to serve, and yet, I think our first responsibility and to go into a community that is not representative of who we are is to really listen, so that you don't come in with the, here, I'll show you, here, I'll tell you, but come in to say, let me listen to what you have to share, what are your needs, and then be able to make the connections. So that's what I'd offer.
I think for me, and I agree with all of you, I think for me, in order to promote inclusiveness, you have to look at your own self. You have to evaluate your internal biases and prejudice and look to see if you promote those or if you actually have those when you go into serving people that don't look like you. You have to really dig in and do your own homework, and work on your own self. And like Kim said, be curious, but be curious about why you feel a certain way or why you think something is different or why you feel that because this person doesn't look like you that you shouldn't provide the type of care that you would normally provide if they did look like you. And so doing your own internal homework is the only way that you're going to be able to face with your own prejudices and biases and demons. And once you work them out, then you can serve people inclusively because you know how things, are for you. And so that's what, that's my answer to that question. So again, at this time, Dara, thank you so much for joining us. We are going to turn it over to Donna at this point. Do we have any opening questions, Kim, that anyone lingering questions or comments that you would like to share from the chat box?
Sure. So what we're getting is, this was great. Thank you, everyone. Every speaker was incredible, offered so much, was well prepared and wise. Thank you so much for sharing perspectives and challenges. All of us do our own homework. Great and important panel. Thank you so much. So we're getting a lot of yay.
Good. And again, this is being recorded, so we're going to share the recording. We also will be sending out a survey. Possibly we may have an event too, based on the survey responses. But thank you so much for your feedback. We are happy to be able to serve you today. And Donna, I am yielding the floor to you.
All right. Thanks, Val, and thanks for getting us all together.
Sure.
So in closing out our discussion, I would just like to invite you all to join me in a brief guided meditation. The intentions of this meditation will be reconciliation, and reconnection. To reconcile means to be brought together, to coexist in harmony. Reconciliation and living with compassion doesn't mean that we have to personally repair all of the difficulties in our life or fix all of the broken things. It just means that we can take a few moments to reconnect and see things through a lens of compassion. When we reflect on our community, as we did today, we can see that each person that we meet holds a measure of struggle and pain. And each person also carries a secret beauty. So when we allow our hearts to really sense the pain and the struggles of others, a sort of natural compassion arises. So I'd like to aid you in bringing that compassion forward. And I invite you now to just sit quietly and close your eyes. Just let yourself be in a comfortable posture. You can bring your attention gently to your body and breath. And just stay with the breath until you feel settled and present. Just going to let go everything that we've discussed here today. Bring into awareness the benefits of healing for all of those communities who have been set apart. And we'll begin with the family, because the family is where we are most vulnerable and where loss can be felt the deepest. If we can't be reconciled here, it's often difficult to reconcile with the rest of the world. So I'm going to recite some simple phrases. It's a list, the kind of a mantra. And as I move through the list, I'd like you to just picture each person and group and feel the distance and pain between them. And hold tender the possibility of restoring connection. Everyone's muted, so I encourage you to repeat the mantra after me, but you can just listen to if that's what you'd rather do. Breathe gently and allow time to sense the reconnection of each. May all mothers and children be reconciled. May all fathers and children be reconciled. May all sisters and brothers be reconciled. May all partners and lovers be reconciled. May all community members be reconciled. May all friends be reconciled. May all women be reconciled. May all men be reconciled. May all religions be reconciled. May all races be reconciled. May all nations be reconciled. May all peoples be reconciled. May all creatures be reconciled. May all beings of every form find reconciliation. I invite you to open your eyes, and I want to thank you for being here today and for considering all that's been discussed. As you go on with your afternoon and your weekend, just try to remember that compassion is a circle that encompasses all beings, including ourselves. Thank you.
And so we are going to end the webinar at this time. As I always end it, I love you all. You are my brothers and you are my sisters. Okay, welcome to my family. And Kim, you can end the webinar if there's nothing else that's left to be said.
Okay.
Thank you.